Okay, so here we are inside the patient's knee. We're just going to take you through a diagnostic arthroscopy. This is the undersurface of the patella here, which articulates with the trochlea. This is a young guy, so he doesn't have much arthritis. We're going to move laterally into the lateral gutter here. And there you can see the usual plical band that we see. And then down into the lateral gutter, we're looking for loose bodies, and he doesn't have any. So we come back up the knee here, back over into the patellofemoral joint, undersurface of the patella, and we move medially now into the medial gutter. Look down the medial gutter for any loose bodies. He doesn't have any loose bodies there. And then we're going to go into the medial compartment here. So the leg is placed on the outside of my hip here. So we're in the medial compartment here. We're going to create our medial arthrotomy. So there's the medial meniscus. So under direct visualization using a spinal needle, we're going to create our medial arthrotomy. So first I'm just going to press on the capsule here just to get a rough idea of where I am. And we're going to come in now with our spinal needle, making sure we avoid the medial meniscus right there and also the medial femoral condyle. Now because this is a ACL, I'm going to use the spinal needle to triangulate and position this portal so that we can get access to the lateral femoral wall. So the main thing I want to do here is avoid the medial femoral condyle. So I just want to make sure that we make this portal in the correct position so that we're able to drill our femoral tunnel in the right position and also gain access to the medial compartment for any work that we have to do on the medial meniscus. So I think that looks pretty good. So I'm going to look back here. I'm going to ask my assistant to remove the spinal needle. Joel, can you take that out? So he's going to do that. And then watching carefully, I'm going to come in with my knife, angle this towards the notch so I make sure I avoid the condyle here. I'm going to make a little cut down here, also looking to avoid the medial meniscus. I'm going to extend this upwards a little bit, again, making sure I avoid the medial femoral condyle, which we're doing here. And that creates our portal under direct visualization. So here we are inside the medial compartment. I've got my probe in now, and we're just going to probe the medial meniscus. So the anterior horn here and the body look pretty good. That's the wave sign we can see there, which is usually indicative of an intact medial meniscus. Just going to try sneak our camera back there and open up the medial compartment looking at the posterior horn, get my probe under the posterior horn here, and I'm probing just to make sure we haven't missed any tears in the posterior horn of the medial meniscus. But this is a young patient and he's got a very intact medial side, so I'm happy with that. So we're going to move from the medial compartment here into the intercondylar notch to look for the pathology that this young guy has. So I get my probe in here, and we've taken out the ligamentum for better exposure, but as you can see looking into the intercondylar notch, this is what we call the empty lateral wall sign. So he's got a rupture, complete rupture of his anterior cruciate ligament. You can see some of the remaining fibers up the wall here, but for the most part, this is where his ACL should be articulating with the lateral femoral condyle, and it's completely gone. So that's the empty lateral wall sign with complete rupture of his ACL. So now we're going to move into the lateral compartment with the leg placed in a figure of 4 position. So we do this avoiding the any sort of damage to the lateral femoral condyle. Can I get the probe again? That's his lateral meniscus. There's a little bit of fraying there, which we'll clean up. I'm just getting the probe into the knee here. So it's important with, and there we see a little bit of a tear. So this is the standard meniscal tear that we usually see with ACL tears. It's a longitudinal tear there of the posterior horn of the lateral meniscus. So you can see it pretty clearly coming through the top of the meniscus here. And if we put our probe into the tear here, we're able to pull this meniscal tissue right into the lateral compartment, which we shouldn't be able to do. So because this is a young guy, we're gonna go ahead and fix this tear. So this is with our 3.5 millimeter shaver in the compartment. We're just gone ahead here and clean up just the fraying here of the body, which we do just gently taking out any unstable meniscal tissue. So I've just got the suction on here, pulling any unstable bits into the shaver. And just underneath our tear here, making sure not to take out any meniscal tissue that we want to preserve. So here you can see we've passed a all-inside stitch into the tear to hold it together for an all-inside lateral meniscal tear. Okay, let's get the cutter. Can you guys just hold the scope there? Yeah. Like this. Okay. So we're going to get, this is our knot cutter down, and then we're just going to push down and cut. And that's it. Let's have the probe. I've also switched portal, so I'm looking through the medial side here just because it was a better shot, more of a direct shot from the lateral portal. So I'm just going to probe this and see. So you can see much more stable there. We've just put a single horizontal mattress across the tear, and I think that's all this guy's going to need. So it's a good repair. So you see we're unable to pull the tissue into the lateral compartment now that we fixed it. So it's a very stable repair there. We'll get a picture. Good. So now we're back in the intercondylar notch. To the left here is the posterior cruciate ligament. You can see the fibers right there to the left of my shaver. And this is our empty lateral wall sign. So we're just going to start clearing away the soft tissue on our lateral wall here to prepare the lateral wall for our new femoral tunnel. So this is a 3-5 shaver. I've just got it on suction here, debriding away this tissue so that we can get a perfect view for our lateral wall for our femoral bone plug. This is a bone, patella tendon, bone autograft that we're doing. So you'll see here, once we've got this cleared, we're going to position our pin and drill our tunnel and then pass the graft. So this is the radiofrequency ablation probe that we use here. And this helps us clean away tissue on the lateral wall. Trying to get all the way back. So I'm just testing out for where my posterior wall ends there. Make sure we clear all of this remnant ACL stump here so we can drill a good tunnel. Okay, let's get the burr ready. 4.0 millimeter burr here. It's a barrel burr, so we're just going to start taking down some of this bone here just to improve our visualization. Okay. Yeah, thanks, buddy. So this shows our lateral wall has been debrided, and we've also completed our notchplasty, opening up a little bit for our tunnel. So I'm going to take the arthroscope out of the knee. We're going to put it into the medial portal, and then we're going to come back and just visualize our posterior wall. So you can see the posterior wall here, and our tunnel is going to go about as far back as we can and about as inferior as we can. So this is about the spot where our new tunnel is going to go, maintaining a posterior back wall. So let's get the guide. So this is so I'm back in the knee here through the lateral portal. So we're going to put our offset guide into the knee. And this is going to hook on our posterior wall. It's a 6.5 millimeter offset guide, which is with a 10 millimeter graft is theoretically going to give us about a 1.5 millimeter back wall. So Richie, you're going to flex the knee, so grab there. We're going to hyperflex the knee to about 120 degrees with it in the right position here. Keep going, Richie. Good, so that's a good position. We've hyperflexed the knee to about 120 degrees, and we're going to insert our pin now. So there's the pin coming through, 6.5 millimeter offset guide. Yep, go for it.
Okay, you got a coker?
And there we can see the pin coming out the skin. Keep going.
You good?
Good, you can stop there. So we're not going to change our position here, and we're going to take out our offset guide. I'm going to flip this around so we don't ding the condyle. So there you can see our pin in a pretty good position. The knee's hyperflexed to 120 degrees. I'm going to turn my eyes around here, looking backwards to making sure that when we insert our hemi-fluted blade, yep, you can do that. And you're going to use a soft tissue protector. So what I do is slide this in along the medial side of the pin. And this, when we put our, you can see the drill coming in over our guide pin here, and this just protects the medial femoral condyle. Great work. Yeah, good work, good work. So once it gets past the medial femoral condyle here, and I know everything's been protected, I'm going to flip my eyes to look back towards our pin. And then I'm going to take this soft tissue protector, or in this case, medial femoral wall protector out. And we have measured our graft to be a 24 millimeter plug. So I'm going to drill to about 25, 26 millimeters here, this tunnel. Richie, you maintain the leg position. Okay, full speed, go ahead. Yeah. So we stop intermittently here just to get an idea of where we're at. This is marked. Just spin it just lightly so we can see where we are. What does that say? 30. So that's 25. So we've got about another 2 or 3 millimeters to go here. Keep going, full speed. Keep going, keep going, keep going. A little bit more. A little bit more. Good. I think he can come out. That's great. So he's going to, again, come out. We're going to stop right there. And I'm going to look back. We're going to angle this hemi-fluted reamer away from the condyle so we don't ding it. And that's taken out of the knee. And we're going to go ahead here and clear all this debris. So let's get the shaver in. Good. So I'm just going to put our shaver in here. I'm just going to turn on the suction and just let it oscillate, getting all of this debris out of the knee. Yeah. So there you can see our femoral tunnel. So one thing I like to do is just bevel out the anterior wall here. So the ACL is going to be coming here. So what we do is just with this 3.5 millimeter shaver on, I put it on forward and I just sort of taper this wall a little bit here, which when the graft is articulating there, it makes a smoother edge so that there's less propensity for the graft to tear as it makes that turn into the tunnel. So I just sort of bevel out the wall. Taking away that sharp edge. Good. Big piece of fat there. So we just turn it on to suction there, clearing this debris. So that's a pretty good view of our femoral tunnel. So this is our passing suture that we're going to place through the lateral femoral condyle, which is going to allow us to pass our graft. So there you can see we've maintained the posterior wall, which is very, very important, critical to this procedure here. And that's a pretty good look at our femoral tunnel. That's a great picture. So we've drilled our femoral tunnel here. Now we're on to the tibial tunnel. So I've taken out most of the tissue here at the footprint of the tibial insertion for our ACL, but I've left a little bit of made a mark where I think is the anatomic position for our tibial tunnel, and that's where I'm going to position my guide there. So the references we use include our PCL, which is just in front there, and then also the posterior margin of the anterior horn of the lateral meniscus, which is right there. So as you can see, that's coming across. And I think a good position is right there, just off that margin of the meniscus. So I'm going to keep this in place, and my assistant is going to lock it down. This allows us to determine the length we get. That's about a 40, and we wanted a 40 tunnel, so good, go for it. Yep. So our guide pin's coming through here. Good, I can feel you there, so just nudge it along a little bit more. Good. Good, perfect, perfect. Okay, so now we're going to take out our guide. This just snaps off the pin and comes out of the knee. So I think that's a perfect position for our tunnel. It's a good length, and you can see our pin there is right in the center of where the remnant tibial footprint is, and it's just off the posterior margin, the anterior horn of the lateral meniscus. I'm going to put a curved curette in here, and this goes over our guide pin just to protect it as the drill comes in. So we're going to drill a 10 tunnel. So this guy's got hard burn. So there you can see it's starting to spin, and we're just waiting for it, and it's in the knee. Perfect. So there's our tunnel. Let's just stick our shaver up there. We're just going to clear all the soft tissue. And then I'm also going to bevel the wall here for the same reason that I bevel the wall on the femoral condyle, just to get rid of this sharp edge here to protect our graft as it makes the turn. So there's the tibial tunnel, and then we look across to our femoral tunnel right there. And this is just looking from outside in down our tibial tunnel. So this is a pretty good look at our tibial tunnel here. I'm just taking away some of this soft tissue around the tunnel just to help with passing our graft. We've beveled this posterior edge here of the tunnel just to take away that sharp edge for our turn into the femur. Okay, grasper please. So the next thing I'm going to do is transfer our suture up from the femur. So this goes up through a little arthroscopic suture grasper, so you can pull that into the knee there, and then grab this suture again, if I can. Yeah, and pull it down through the tibia. So now you see we've got a path with this suture, our passing suture, all the way from the femur down the tibial tunnel, and this is going to be used to pass our graft. So there's our graft. This is the patella and subsequently femoral bone plug that's coming up into the knee. So Richie, go ahead and get a little attention there. So you can see it's being pulled into position in our femoral tunnel. Can I have the probe, please? So he's going to keep tension. Joel, you're going to make sure that it's going in okay at this end. So I'm going to sneak my probe in here just to help direct the graft. Yeah, that looks really good. Keep going there, Richie. Good. Keep going, keep going, keep going. Perfect. So that's in a great position, and I've marked it here so you can see that's where our bone ends and that's where our tendon starts. So I think that's in a great position. We've got the graft angled posteriorly, which is good. And you can see our bone plug is fully seated within our tunnel there. So that's exactly where we want it. Okay. So we've made a little notch there where our pin's going to go. So my assistant here is going to pass the guide wire again. Okay, so this is the pin going in. So you can see it's seated now in our tunnel. That's perfect. Let's get the tap. So the knee's hyperflexed again to 120 degrees, exactly how it was. You can put that over the guide pin, how it was when we drilled our tunnel to maintain the same position. And I've got the soft tissue protector here to protect it. So this is our tap here. Let's try. So this is a tap just to make some threads in the condyle for our for our interference screw. So we're going to go down to about 25. That's perfect. The whole time we've got our soft tissue protector in between the tap and our graft just to protect the graft. So there's our tap coming out of the knee. Just hold the guide pin. Good. And then we'll put the guide pin back in there. Perfect. This is a biocomposite 23 length, 7 diameter screw. So there you can see it coming in. I want to get it in the exact same position, knees kept in the same position. Good. And it's great fit here. Soft tissue protector out. Good. Switch this over. Good. So there is our interference screw going in, seated nicely, and then we'll take our, what's that, mallet? Good. So there you can see our screw and our graft. So we've placed our femoral screw and we've cycled the knee about 20 times. And there you can see our new ACL. It's fixed on the tibial side. If you look back there, this is the knee in full extension. So we make sure that the patient can get full extension and there's not any impingement anteriorly here. And then if we flex up, you can see our new ACL coming across here. Again, moving down into full extension.